Okay, hi, and welcome to part four. In part four of this electrophysiology series, we're going to be talking about the action potential specifically of pacemaker cells. In the last talk, lecturette, whatever you want to call it, that I did, I talked about the action potential, how cells depolarize of the general myocardial cells. So usually, the ventricular myocytes. How do the ventricles contract? But the pacemaker cells are different. They contract in a different way and they contract to a different stimulus than the ventricular myocytes contract to. And it's important to understand how the pacemaker cells work because they're the pacemaker cells for the heart. And if they're not working, we get into real trouble. And understanding how they work gives us a bit of an idea of how some of our pharmacology and how some of the physiological conditions that our patients experience manifest in the heart and change the qualities of the pacemaker cells. So this is available for you guys if you want. You can go to SlideShare. And these are the topics that we've done so far. We've talked about fundamentals, movement through the membrane, electrical flow in the heart, and the action potential of myocytes. Now we're going to talk about the action potential specifically of the pacemaker cells. Some of the priming questions that I want you guys to think about, because you should be able to answer these at the end of this talk, is how can the sinoatrial and the AV node cells depolarize without being externally stimulated? They have autorhythmicity. They are able to depolarize themselves spontaneously. How do they do that? What are funny channels? I love funny channels. One of the coolest things. We'll talk about what funny channels are. And what ions flow through those funny channels in the cell membrane. Pacemaker cells, unlike ventricular myocytes, don't have phase 0, 1, 2, 3, 4. They've only got a 4, a 0, and a 3. Why is that? How is it that they're working so differently? And then we're going to compare a little bit, and you should be able to compare the action potential of a pacemaker myocyte versus a normal ventricular myocyte. So here are the action potentials charted out, time on the x-axis, voltage on the y-axis in millivolts. And you can see that they're different. And in particular, if you take a look at the SA node and the AV node, you can see that they've got quite a different shape than the normal ventricular depolarization, which we studied in the last talk. So the different tissues in the heart depolarize in different ways. And the SA and the AV node are markedly different, and they have different electrophysiology. These are the pacemaker cells, sometimes called the autorhythmic cells, because they can automatically generate their own rhythm. So let's talk through this a little bit. If you look in the first picture at the top there, the one labeled action potential, you'll see that this is an action potential of a pacemaker cell. And it looks different. It's a different shape and it's got different numbers and it does slightly different things. So what happens is when we're looking at the ventricular myocytes, when we're in phase 4, the phase between depolarizations, phase 4 is stable. Phase 4 keeps a regular transmembrane potential. There's a constant charge on the inside of the cell that doesn't change. In pacemaker cells, that's different. There's no stable phase 4. The phase 4 in pacemaker cells automatically rises over time, and that's because pacemaker cells are leaky. They're much leakier to ions than ventricular myocytes are. And they're leaky because they've got an extra channel, and that extra channel was discovered by the French, again, and yay, France. And in one of the sort of beautiful moments of science that shows that this is humans that are doing this activity, this collective enterprise, they decided to call these funny channels that allow sodium to go in and potassium to go out at the same time, funny channels, because it was funny. It was weird, funny in the sense of weird. And so they're actually called funny channels. And these funny channels sit in the membrane of the ion of pacemaker cells and they leak. They leak potassium out and they leak sodium in. And they leak more sodium in than they do leak potassium out. So we get more positive ions moving into the cell than we get moving out, the sodium moving in and the potassium moving out. And so gradually the charge inside the cell starts to build up to be more and more positive. And by the time it hits around minus 50 millivolts, another ion channel is triggered, and that's the calcium channel, and it's the quick or the transitory calcium channel. So there's a quick opening of these small calcium channels, which allows calcium to rush into the cell, which makes the inside of the cell even more positive. And then when we hit around minus 40 millivolts, you can see there's a sudden spike there, and that's our phase zero. We get some long-lasting calcium channels opening up. So there's a quick little flash of calcium from the transitory calcium channels, and then there's the long-lasting calcium channels. And that causes our phase zero rise. It's not sodium, like in the ventricular myocytes, it's actually calcium rushing in. And then as the calcium rushes in, we switch over into our phase three, which is where potassium, more positive ions, are exiting the cell. And we get a net efflux of positive ions, and the cell starts to go back on the inside to being negative. And it gets back down to minus 50 or minus 70 or something like minus 70, I think it is. Numbers aren't that important. And the cell then resets, and the funny channels reset and start leaking again. We have to get back down to that low voltage in order for the funny channels to reset. So if we take a look at how that looks in this bottom chart, you can see that in a pacemaker cell, we've got this slow leakage of sodium in to the cell. No, yeah, sodium's coming into the cell, making it positive. Potassium is leaking out. So the potassium's going down, sodium's going up. And when we hit a certain threshold, we hit our transitory calcium channels, and we get a quick spike of calcium coming in through the transitory channels, and then those channels close. But they're activated long enough to activate our long-lasting calcium channels, and we get this big spike of calcium coming in, and then we get our potassium rushing in, rushing out, and on balance, if you were to trace sort of this shape, it looks like this shape up here. Calcium or sodium comes in, calcium comes in, lots of calcium comes in, calcium stops coming in, potassium exits, we go back down and we reset our cells and we're ready to go again. So if you want to look at the Colbeck's notes of that, we have resting membrane potential is what we're charting here, and we get a spontaneous phase 4 rise. That's this phase 4 here. That doesn't happen in normal ventricular myocytes. That happens in the pacemaker cells, and it's what makes the pacemaker cells special. They're leaky, and because they leak towards a positive charge, which makes them spontaneously depolarize. That's due to funny channels, as we said, and the I stands for, again, the French intensité du courant, so the intensity of the funny channels or the flow of the funny channels, and also due, once we get up to about minus 50 here, due to the transitory calcium channels, which open up. So these funny channels, we say, are non-specific cation channels. So they allow cations, positive ions, to go through them. So they allow sodium to come in, the influx, and potassium to go out, the potassium efflux. At a negative membrane potential, so when we're down here, sodium and calcium influx is greater than the potassium efflux. So we've got more positive ions, more cations, coming into the cell than we have going out of the cell, so we gradually depolarize. We get more and more positive, more towards neutral. The action potential in the sinoatrial and the atrioventricular nodes is similar, but pacemaker cells in the SA node do this more quickly. So they depolarize more times a minute. And since they depolarize, they start those gap junction transmissions happening, and they cause the rest of the heart to depolarize. So these are the pacemakers. These are the leaders. Because the SA node resets so quickly, it sets the pace for the rest of the heart. And of course, if the SA node cacks out for whatever reason, the AV node takes over. It takes over a bit more slowly, but it does take over. It's our redundant backup system. So that is the basic outline of the action potential of the pacemaker cells. So if we go back to this diagram, which I love, then what we can see that's a little bit different is that there's no fast sodium channels in the pacemaker cells. Instead, what we have are these funny cells or funny channels in the pacemaker cells that allow sodium in and potassium out. And they allow more sodium in than potassium out. So we get more positive inside the cells. That opens up the calcium transitory channels and then the long-lasting calcium channels. And that's how we get depolarization of the pacemaker cells. So let's look at this sort of step by step. We'll go through the 4 steps, phase 4, 0, 3, and then back to 4 again. So in phase 4, the funny channels are open, and as we get more and more positive, we get our calcium channels, the transitory calcium channels, opening up. And once we hit here, these transitory calcium channels that have opened and the funny channels that are open, that have allowed sodium and calcium to come in, make the inside of the cell more and more positive, and then our long-lasting calcium channels open, and that's the beginning of phase 0. So in phase 0, we open up our long-type calcium channels. In the myocytes, that would be the sodium channels that cause the big positive spike. But in pacemaker cells, it's calcium. So the calcium enters, but it actually enters a bit more slowly than the sodium enters in the ventricular pacemaker. So you remember in the ventricular cells, when we have depolarization, it's almost a vertical rise, right? It just zoop, shoots right up, and that starts our depolarization. But here, the calcium's entering more slowly, so we've got more of a gentle rise. It's a bit quick. There's no calcium prolongation phase. We don't have a plateau in the pacemaker cells, which means that they repolarize fairly quickly. So they're able to depolarize and repolarize much more quickly than the ventricular cells, which means they can go faster. These are a lot more like nervous cells. We don't really need the depolarization to last. We just need it to happen quickly and regularly. So there's no fast sodium channels. We don't get a phase 1. That's why we go from phase 4 to phase 0. Remember that vertical phase 1 in the ventricular myocytes is due to sodium channels opening. Well, we don't have that happening in these. So the calcium channels are rapidly deactivated, so we don't get a phase 2. We jump right into our phase 3. Phase 3 in the ventricular myocytes is that plateau phase. We don't have a plateau here because the calcium channels open and then they close and then the cell resets. So in phase 3, we get our repolarization when the calcium channels close and the slow potassium channels open, so we start exiting some of our potassium efflux. We get more potassium leaving the cell, so more positive ions leaving the cell means the inside becomes more negative. And then we get down past this depolarization threshold, back down to about minus 40, minus 50 or so, a little bit further, and our pacemaker cells reset and the funny channels reset and they're able to start working again. So if we go back to this other diagram that we had, this is our long calcium channels, long-lasting calcium channels opening, and our potassium efflux cells opening up. And so the closure of the slow potassium cells, which was opened during the previous repolarization, happens, and we get potassium leaving the cell, so the cell becomes more negative. And that cyclic rhythmic excitation of the cell depolarizing and then resetting and then slowly leaking up and then repolarizing again is that autorhythmicity of the pacemaker cells. That's how they work. Now, there's an important point here, and it explains something that happens physiologically to our patients. If you have a patient who is hypoxic, most people think that if I were to, suddenly duct tape your face closed, what I would go into as a patient is just destabilize down into VF, and then I die from VF. And that's not actually true. Hypoxia initially does not cause VF. It can lead to VF later, obviously. But if you were to hook one of your don't do this, but hypothetically, thought experiment, if you were to hook one of your classmates up to the ECG monitor and then stick their head underwater so they couldn't breathe, what you would actually see them do is not tacky up into VF, but braddy down in a normal sinus rhythm, braddy down into a severe sinus brad, which could then spin off to a VF or might actually just go straight into asystole. And I've responded to patients who were choking, and when we get there, they're unconscious, but they're still alive. They've still got an organized electrical rhythm. And you think, man, they're going to be tacky as anything. But they're not. They're in a sinus brad. And the reason they're braddying down is because the cell has to repolarize properly in order for the funny channels to open up again and to allow this spontaneous phase 4 rise. But cellular hypoxia obstructs this phase 3 and doesn't allow the pacemaker myocytes to properly reset. And since they can't properly reset, we don't get that leak, or at least the leak is much, much slower, so the cells slow down. So if you're ever in the unfortunate clinical situation of a severely hypoxic patient, maybe complete airway obstruction, and you're waiting for the tachy to VF happen, don't be surprised when you see that that doesn't happen. What instead they do is they braddy down in a sinus brad and then go into some sort of lethal rhythm, either asystole or VF, or maybe they stay in a slow, like idioventricular or something like that, but because the ventricles have taken over because the pacemakers aren't working. But the reason for that is because the cells need oxygen, the pacemaker cells need oxygen in order to reset properly for the funny channels to be able to work. Really important clinical application of sort of the esoteric ionic physiology of what's happening in the heart. So, summing up, if we compare the two, let's take a look at the normal myocytes there on the one, this is the normal ventricular myocytes, and then pacemaker myocytes. So the membrane potential in a normal myocyte is around minus 90. In pacemaker myocytes, it's a little higher. It sits at around minus 60 millivolts. What causes a normal myocyte to depolarize? Well, normal myocytes are normally stimulated by other myocytes that are depolarizing, and that wave of depolarization enters into the normal myocyte through gap junctions. Pacemaker myocytes don't do that. They don't wait around for somebody else to depolarize them. Because of this spontaneous leaking through the funny channels, they depolarize themselves. So that's what leads to the action potential firing. The rise phase of the action potential in normal myocytes, that abrupt rise, is sodium entry, whereas in pacemaker myocytes, it's calcium entry. So it's a different ion that stimulates them. Popular test question in my classes for anyone who's taking classes with me. Repolarization phase. So in the myocytes, because we want depolarization to last for a while, the depolarization is extended with that calcium plateau, but we don't have that calcium plateau in the pacemaker myocytes. It depolarizes and then just spontaneously repolarizes. Again, it's resetting quickly because it's setting the pace for the rest of the heart, and it needs to reset quickly so that it can be ready to depolarize again. So the normal myocytes don't usually hyperpolarize, and what we mean by that is they don't become extremely negative on the inside. They go back down to minus 90 and they kind of stay there. That's the equilibrium for potassium, and so they tend to just sit there, and they'll sit there forever unless they're stimulated. The hyperpolarization in pacemaker cells is necessary because you need that polarization to reset the funny channels, but it doesn't really like hyperpolarize. It just needs to get down to its minus 60 millivolts in order to reset. The action potential in normal myocytes is longer than in the pacemakers, as we've talked about, because there's no calcium plateau. So it's about 200 milliseconds in normal myocytes and 150 milliseconds in pacemaker cells. And you might think, 50 milliseconds, like, who cares? Well, it's about a quarter faster. And that's really what matters. It's the relative speed that matters. You'll see the pacemaker myocytes are faster than the normal myocytes so that they can set the pace. The refractory period takes a while in normal myocytes. There is a period where if you try to stimulate a normal myocyte, a non-pacemaker myocyte, it won't be able to fire off. It has to reset its ions in order for it to be able to work. That's not true in pacemaker myocytes. Pacemaker myocytes have their own autorhythmicity, but if an external ectopic foci stimulates a pacemaker myocytes, it'll say, I'm ready to go again. As soon as it fires, it's almost immediately ready to go again. And that's the difference between the pacemaker myocytes and the normal myocytes. So that's the rough idea. If we put that all together, we can move here from the top of the heart down to the bottom of the heart. And you can see the SA node there in pink fires quickly, fires rapidly, and spontaneously repolarizes off to fire again. The atrial muscle has a little bit of this calcium plateau. AV node, another pacemaker site, does the same sort of phase 4, phase 0, phase 3 depolarization of a pacemaker cell. So it's got the normal pacemaker cells. And then when we get down to the ventricles, we want the ventricles squeezing for a good long time because they're big and there's a lot of blood to squeeze out. So we want a prolonged contraction. And this is our typical sort of action potential diagram for the ventricular muscle. So SA node, AV node have funny channels, which are leaky, which cause them to spontaneously depolarize at a fairly rapid rate. Atrial and ventricular muscle do not have funny channels, and they rely on stimulation from the autorhythmic, from the pacemaker cells, in order to fire off. Hopefully that makes sense. This is it's a bit of a deeper dive. I don't think you necessarily need to understand the ions of the pacemaker cells in order to be a good paramedic. But it is interesting academically to understand how they work. And it also has an application physiologically, clinically, when we see patients who are hypoxic braddying down because their funny channels can't reset. This video is posted up on paramedicine.com if you want to go see it there. It's housed on YouTube, but we got it on paramedicine.com. The slides are on slideshare.net, so come visit paramedicine.com and you can see all the stuff that's here, and it's free. You can download the PowerPoint and use it to help teach others so that they can help patients, which is the whole idea of why I'm doing this. Hope you enjoyed it. Leave your comments in the questions. Thanks very much. Oops. Okay, turn this off.